Hello, everyone, and welcome to this new Retina Radio miniseries, Matching Patients to Therapy in Wet AMD. My name is John Kitchens, and I'm joined today by two panelists. The first is Dr. Adrienne Scott, who is chief at the Wilmer Eye Institute, Bel Air, and is an associate professor of ophthalmology at the Wilmer Eye Institute in Baltimore. Dr. Scott, welcome to the show.
John, it's a pleasure to be here. Thank you for having me.
Absolutely. And our other guest needs no introduction, but we will introduce him. It's Dr. Carl Regillo, who is the chief of the Retina service at Wills Eye Hospital in Philadelphia and is a professor of ophthalmology at Thomas Jefferson University, also in Philadelphia. Carl, thanks for joining us.
Thanks so much, John. It's a pleasure to be here. Thanks for having me on the program.
This is going to be a really interesting series where we will profile various kind of real world patient cases. And we're going to explore which therapy options these patients really are best suited for. We'll first hear about the details of each case from Dr. Scott and Dr. Regillo. And then after the break, we'll reveal which therapy our panelists would select. So let's kick things off with Adrienne. Dr. Scott, give us your case. Share with us what you have and what you have in mind for this patient.
Sure. Thanks, John. So the case I have to share is a case of an 83-year-old man who comes in, referred from the anterior segment service soon after his multifocal IOL placement for new onset CNV. This was actually back in 2014 when he came to my clinic for the first time. And he was noted to have neovascular AMD new onset in 2014 in one eye. And in his other eye, he has intermediate AMD with extensive large soft drusen. At that point, we initiated a aflibercept therapy, and he lives probably in a suburb outside of Baltimore, probably about maybe 30 miles away, drives himself in each visit. And we are treating him with a aflibercept regularly, starting with a series of three, initiation we call loading doses. And as I try to extend gradually after monthly treatment, his neovascular AMD remains active with a large subfoveal PED and moderate amount of subretinal fluid that appears to be stable when I treat him about every 4 to 6 weeks. But as I try to utilize the treat and extend protocol, adding on 6 weeks, 7 weeks, 8 weeks, and his subretinal fluid increases each time I try to extend the treatment interval.
All right. So Carl, here we have a case that Adrienne has presented, and these cases are all too common. The patient that you just can't really extend out, an 83-year-old gentleman who is being treated with a aflibercept, and you just can't seem to get them out to that optimal interval. They drive themselves, so they're very self-sufficient. It's a big burden on this patient. Carl, what are your thoughts about a patient like this?
No, you're absolutely right. Burden is a big factor here. This type of patient needing to come in this frequently, every 4, 5, or 6 weeks for optimal exudative control, probably represents at least a third of our patients using the current therapeutics, the current anti-VEGFs we've been using now for going on 15 years. Although we can extend many of our patients 8, 10, 12 weeks, and therefore get good results with less burden. This is a frustrating group, and it's hard for patients. We all know our patients often rely on caregivers to help them come to the office. This patient, I think, is fortunate that at least the fellow eye, I believe, sees well and probably can drive themselves. And a lot of my patients will drive themselves to and from the office. But if that fellow eye or both eyes are just simply not seeing well, you've got even bigger challenges at hand. And I think we're all speaking the same language. We need therapeutics that last longer. There's no doubt about it, not only to decrease the treatment burden, but to make the treatment more forgiving in that, the more recurrences we have or the more fluid we allow, the worse the vision outcome ultimately is going to be. The patient will lose ground eventually. So having something that's truly much more durable than what we've been using, I think also holds the promise for not only more convenience, if you will, but I mentioned being more forgivable, if you will, for getting better long-term vision outcomes, less recurrences, less disease activity over time in a cumulative fashion.
You're so right. That forgiving nature of a therapeutic, I think too many times our patients just fatigue And we sometimes fatigue. And so we let them slip. We say, well, you know what? Ideally, you should be 4 to 6 weeks, but 8 to 10 is good enough. And that's where we get that downward decline of vision that we just don't realize because it's death by inches. Every visit, they lose a little bit of ground. And before you know it, things like the 7-Up study, where we see patients who just return back to baseline. So, Carl, you also have a great case. And just to remind our listeners, we will come back and hear the therapy of choice that Dr. Scott used for her patient. But I'd like to move on to Dr. Regillo's case. Carl, tell us a little bit about your patient.
Well, in many ways, it's very similar. It doesn't go back quite as far in terms of my management. This patient came to me more like about 8 months ago. It's a 77-year-old female who noticed some distortion in her left eye for about 3 weeks in duration, brought that up to her primary eye care provider. There was suspicion for wet AMD in the left eye, the symptomatic eye. And that patient in turn was referred probably within about a week. She was seeing me. When she presented to me, she came with signs of AMD, drusen in both eyes. And her visual acuity was decreased in the affected symptomatic left eye to 20/60. Her right eye had dry AMD with good vision, 20/25. She was not symptomatic there. OCT showed central subretinal fluid and a lesion consistent with type 1 choroidal vascularization, a little bit of intraretinal edema too, not a lot, mostly subretinal fluid. And a confirmatory fluorescein angiogram was performed, not something I often will typically do, but nonetheless, the patient did get it at this exam, at the initial exam, and it did show central CNV with leakage as expected. So we started treatment the same day. I also utilized aflibercept as the anti-VEGF that she was started with. She received 2 monthly injections, 2 injections over a 4-week time frame each. Great initial response, completely dried up the macula. 4 weeks after just the second injection, the macula looked perfect. Visual acuity, I should say, as good as it's going to be, no signs of exudation. And the visual acuity had improved to 20/30. She was very happy. And it came time to deciding, do we start extending? And that's what I did by 2-week intervals. And the patient made it out 6 weeks with aflibercept, looked great, again, holding 20/30 vision. But of course, I jumped to 8 weeks as we ordinarily do, again, by 2-week intervals for the extension. We're now getting into the maintenance phase and trying to figure out this patient's ideal interval. And we had a significant amount of central recurrent subretinal fluid, again, mostly subretinal fluid. And we always scratch our heads. We hear about how subretinal fluid might be better tolerated than intraretinal fluid, and that indeed is what the literature suggests. But nonetheless, the visual acuity dropped, and it was probably about at least 150, if not 200 microns of subretinal fluid. And visual was 20/50, 8 weeks after the last dose. And so recurrent signs of exudation, decreasing vision, and symptomatic. I, of course, made the decision to go back to 6-week treatment intervals. And I re-challenged her one other time after several cycles of 6-week intervals. I tried to go back to 8, and of course, the exact same thing happened, very predictably, had fluid, decreased vision. And so she kind of failed twice to extend to 8 weeks. And I've kept her on every 6 weeks since. Now, she hasn't been much more than, again, 8 months into this, but she sort of declared herself as a frequent flyer, if you will, getting treatments every 6 weeks to maintain a good-looking macula anatomically and her best vision at 20/30. So there we have it, and in many ways, very similar to Adrienne's case.
That's a great case, Carl.
A fantastic case. Adrienne, I've got a question for you. Carl mentions the frequent flyers. In a patient like this, we've seen her now fail twice going out to 8. Is she going to forever be a frequent flyer?
That's a really interesting question. I do find that sometimes if you almost start over again with some patients, walk back the interval and just go very slowly increasing your extension treatment interval, they can sometimes increase their interval, but you start to get a sense in some patients how active their neovascular AMD is and how much fluid they tend to reaccumulate. And I think we're starting to get that sense earlier and earlier in some patients. And so, I think we have lots of these patients that seem to be tolerant of 6 weeks, 7 weeks, 8 weeks. But when we try to go past 8 weeks, they just, reaccumulate fluid, and it's almost like you're starting back over again.
Yeah, absolutely 100% agree. And what's interesting is we may have some new treatment options on the horizon. So let's take a little break here. And when we come back from the break, we're going to hear how Dr. Scott and Dr. Regillo manage their patients. Welcome back to the new Retina Radio miniseries, Matching Patients to Therapy in Wet AMD. I'm John Kitchens here with Dr. Carl Regillo and Dr. Adrienne Scott. So Adrienne, before the break, we heard about a real-world patient case that included an 83-year-old gentleman with new onset wet AMD in one eye that received aflibercept injections. But when you tried to extend that patient out beyond 4 to 6 weeks, he got new subretinal fluid, was symptomatic. Fellow eye was dry. Patient was very capable of supporting himself, drove himself to his own appointments and whatnot. Talk to us a little bit now in today's day and age about where you go with a patient like this.
Sure. Thanks for the question, John. So, the interesting part about this patient is I started treating him in 2014. So, approximately, 7 years or so ago. And his family is getting increasingly worried about him driving back and forth from his injection appointments so frequently. And although the other eye is holding and stable, there's increasing concern about him driving after injections. So I definitely want to find something that would extend his treatment interval longer while maintaining his vision. So in this case, this is somebody who I think would be a great candidate for faricimab injection. It's a place where I think many of us are excited about the potential use in individuals who may not be able to be completely dry on their current treatment interval, or when you try to extend the treatment interval, the fluid definitely recurs. So a high treatment burden is definitely a case for somebody would be a good candidate for faricimab.
So Carl, faricimab, what can we expect from faricimab that we don't have with our current agents?
Well, I think we're going to have efficacy that's at least as good. And there are hints that it might even be a better drying agent. At least we saw that in the DME phase trials compared to aflibercept. It dried better. And I think there's some translation into wet AMD for some of our patients too. But at the very least, I think the big added value here for faricimab in this setting, for Adrienne's case, is extended duration of action, better durability, clearly. And with a safety profile, we have to mention, with the safety profile that's on par with, very comparable with the drugs we have been using, aflibercept, ranibizumab, and even bevacizumab. Technically another choice might be brolucizumab, but I don't think the durability is all that much more. And I think we all have the same concerns around safety, and that's why it doesn't get a lot of use as the next step for this type of patient. There really is no other step for this patient with the same safety profile as the drug Adrienne already been using for years now, and that's aflibercept. So we'll await. I think faricimab's an excellent choice, and I'd have to say perhaps also on the table the port delivery system as a potential option for this patient too. And the patient's going to need to weigh the pros and cons, a trip to the OR and all that. But faricimab is a very logical next step. And that's for both patients that established treatment for years, just like this, or even our new patients.
And Adrienne, how would you dose this patient when you start them on faricimab?
Yeah, I would try to follow the clinical trial data as closely as I could, first with several loading doses, but I would definitely try to follow the clinical trial as closely as I could prior to any sort of extension. If I can see them back after the first set of loading doses in about a month to assess disease activity, which is what I believe was followed in the clinical trial, at that point, I would assess the drying impact on the macula and potentially extend from there.
Fantastic. Carl, you told us about a patient who is a 77-year-old, just 8 months ago, diagnosed with wet AMD in the left eye, 20/60 vision initially, great improvement back to 20/30, very happy. But as soon as you went out to 8 weeks, this patient started to get new subretinal fluid with symptomatic vision dropped to 20/50. What would you choose for your patient as the next step?
Like Adrienne's, we're in a similar situation. The only real difference I think here is that my patient's of more recent onset, but think the patient has pretty much declared themselves as someone that needs frequent treatment, and it's not likely to change much over time. And I agree that what Adrienne mentioned, that sometimes we can extend them a little later on down the line after a few more years of treatment sometimes, but the change is usually not a lot. And this patient is itching for something. My patient, I didn't mention it, was actually coming from quite a distance and really found the trip burdensome and did also rely on family and so forth. So they were highly motivated to want to have real extension of treatment intervals. And so, although faricimab is a good choice here too, my patient was very interested in the port delivery system. The patient also, I have to throw in, gets very anxious about the injections. Tolerates them reasonably well, like most of our patients, but is super anxious. And what I've found in my experience with port delivery system over the course of the clinical trials is patients don't necessarily mind coming in to the office, but they certainly mind and would prefer not to have to get an injection too. So, I told the patient, look, this is an option. It's been FDA approved. It requires a trip to the OR, and then we can do pretty much everything else in the office, unless there's some complication, and we'll go over all that. But nonetheless, the patient was very motivated with the notion or the thought of having a treatment at 6-month intervals. We know from the clinical trials we can get it reliably 6 months of durability here, and yet still come in maybe once or twice in between at the very least to get the device checked and make sure their disease activity is under control. So this patient was really motivated after hearing about the FDA approval for the port delivery system with ranibizumab to go that route.
And Adrienne, what are your thoughts on Carl's choice of a surgical option, really, with a different set of potential complications for his patient?
Yeah, I think it's an absolutely excellent choice. And that's one of the great things about where we are now is we have multiple choices to discuss with patients that, accomplish the goals of being an efficacious treatment, maintaining and even gaining vision for the patient with a relatively low incidence of side effects. So we've got great choices. I'm interested also in the patient's take on things. How do they feel about going to the operating room in some cases? I think some patients are actually really excited and eager to try the operating room, the PDS placement. It wouldn't be a good choice for patients with prior conjunctival surgery, prior glaucoma surgery, perhaps very thin friable conj may not be a good candidate for the PDS system. But I do find too, even just mentioning the idea, that patients seem rather excited about it, about the prospect of a surgical, of a depot long-acting treatment.
And Carl, many of our studies are in treatment-naive patients. Can we expect PDS to really give us 6 months in the real world?
Yeah, I do think it's realistic. And of course, I'm speaking because I know, and we all know the results of the latter trial in which the device was refilled more on an as-needed basis, and we got a good sense for its durability. In the real world, I think if we take the full spectrum of wet AMD previously treated, of recent onset, and known to be responsive, and that's most of our patients, it's a very rare patient that doesn't respond to anti-VEGF. Yeah, we could get at least a year on average. However, we might be selecting our sort of highest need, most frequently treated patients first. So maybe it's not going to be a median of a year or more at first, but I think we're going to reliably get 6 months. It was up north of 95% after each refill or around each refill cycle. And that's from the Archway study. And now we're hearing the portal extension data give us that degree of reliability, that is 95% or more patients did not require any supplemental injections before the 6-month refill. So I think its performance has been outstanding. And I think Adrienne's right. It's going to probably be a little more select patient population because there are going to be patients that aren't interested in going to the OR, are not interested in a device, are not interested in necessarily taking on some additional added risks, especially upfront or early on, associated with the surgery and the device. That's unique.
And Carl, we have 2 new therapies launched by the same company, which is absolutely unprecedented. Are these 2 therapies competitive with one another or complementary to one another?
Yes, they are both. Yeah, there's absolutely going to be some patients that are really going to struggle to make a decision, or even the doctors guiding patients like one versus the other. I guess it's how much more durability do you want? Do you want another month or so? Do you want to go from 8 to 12 or 12 to 16 in some patients? If that's all you need or want, and you tolerate the injections well, faricimab may be your first choice. If it's new onset wet AMD, technically PDS doesn't have that label. That doesn't mean in the future we won't try it in that setting. But the port's going to be a more select patient. There's no doubt about it, willing to take on the trip to the OR and so forth. And so, and that's the patient that's really motivated for true sustained delivery, 6 or more months of an effect, a good effect, that is good disease control. So it really is going to depend a lot on both physician and patient risk-benefit analyses here.
Yeah, I can say from my personal experience with port delivery, the patients in the study that we had in the latter study were so, and Archway were so unbelievably happy with the port that they want it in their fellow eye if they have fellow eye wet AMD. Adrienne, last question for you here. We're going to have these 2 new therapies. We've talked about them in recalcitrant patients or patients with a high frequency of treatment. Are these therapies also going to be appropriate for new patients? How are you going to implement them in your clinical practice?
Yeah, I think that's a great question, and a lot of it has to do with really the patient. Comes down to what they want, and as Carl mentioned, kind of the risk they're wanting to assume up front. Some patients may not be candidates for the operating room for whatever reasons, cardiac issues, or they're on, anticoagulation that may give you a little bit of pause to take them to the OR for such a device for the PDS. But I think it's going to come down to patient desire. And again, I've kind of been even mentioning that the port delivery system is coming to market. I've been, even talking with patients, and they're excited about it, and more so than I would think. Being more, risk averse to put them through a surgical risk, but the patients are really excited and they want it. And they're excited to see kind of what the efficacy is of the device. So I think that we will get a feel for what the PDS does in our current patients that we've been treating with anti-VEGF, but I don't think it'll be long before in select patients we'll be using it on treatment-naive patients.
What great discussion. That's a wrap for this episode of Matching Patients to Therapy in Wet AMD. We have 2 more episodes coming out, so stick with your podcast feeds. And on behalf of Dr. Adrienne Scott and Dr. Carl Regillo, I'm Dr. John Kitchens. Thanks for joining us.